ready to begin? Thank you, Geraldine. Oh, there's Jean. That was the person I was most concerned about hearing from. All right. Well, welcome back. It's time for our keynote speakers. And one of the challenges we faced pulling together our list of speakers is, what do you do when you want to hear from more than one person? It turns out the answer is you don't make that decision. You ask them both to speak. So we have two keynote speakers today. Dr. Jean Hall and Dr. Dot Neary. Both of them are on faculty at KU Lawrence. Dr. Hall will speak first. There'll be she'll be followed by Dr. Neary, and then at the end of that time, we'll have a question and answer session for both of our speakers. Jean Hall is a professor in the Department of Applied Behavioral Science and is the director of the Institute for Health and Disability Policies and the Research and Training Center on Independent Living at the University of Kansas. She received a doctorate in disability studies from KU. She has an extensive background in the evaluation of healthcare programs, especially for people with disabilities or chronic illnesses. Dr. Hall is currently working on a federally funded project to assess the effects of health reform on the health and employment of Americans with disabilities. A priority of her research is to give voice to people with disabilities and their experiences with accessing healthcare and living in their communities. Dr. Hall, it's all yours.
Thank you so much, Jeff, and thanks everyone for sticking on. It's been a great day so far. I've learned a lot and I've appreciated hearing all the different perspectives. I am going to talk about health disparities among people with disabilities, look at some of the data and research on what those disparities are, but then also look beneath the surface and try to understand the reasons for those disparities and how we as healthcare providers can help address those disparities within the population. So next slide, please. This is a graphic from the World Health Organization, and I'm going to read it so in case we have any people with visual impairments. The World Health Organization estimates that there are over 1 billion people globally who experience a disability, which is about 1 in 7 people. People with disabilities have the same general healthcare needs as everyone else. They get the common cold, they get the flu, they get broken bones, just like anybody else. But when they are in the healthcare system, they are 2 times more likely to find healthcare provider skills and facilities inadequate. They are 3 times more likely to be denied care, and that does happen in the United States. I hear about it all the time. They are 4 times more likely to be treated badly in the healthcare system. Half of people with disabilities cannot afford healthcare, and they are 50% more likely to experience catastrophic healthcare costs, and those costs are likely to put them or their families into poverty. Next slide, please. Globally, 970 million people need glasses or low vision aids. 75 million people need a wheelchair, but only 5 to 15% actually have access to one. 466 million people have disabling hearing loss, but globally, we can only satisfy about 10% of that need and about 3% of that need in developing countries. All that said, making healthcare services accessible to people with disabilities is definitely achievable and can reduce some of these disparities. Some of the things that we can do is remove physical barriers to health facilities, information, and equipment, and I will be talking about that. Make healthcare affordable. Affordability is a problem for all people in the United States at some level, but people with disabilities have healthcare costs from 4 to 7 times that of people without disabilities, so it's really magnified for them. We can train all healthcare workers in disability issues, including disability rights, and we can invest in specific services such as rehabilitation. And I would add there, rehabilitation is about restoring function. So if you have an injury and you want to restore function to what you had before the injury, that's what rehabilitation is. But for people with disabilities, habilitation is also important. If I'm a person with cerebral palsy and I get contractures in my arm without PT or OT to help, that's habilitation. And historically, health insurance didn't cover that at all. So for people to maintain their function, those therapeutic services were not covered. The Affordable Care Act required that health insurance cover habilitation in addition to rehabilitation, but what we're finding is that it's not equitably covered. So it's still difficult sometimes for people with disabilities to get that habilitative service that they need to retain function, because our healthcare system is about fixing people, and habilitation is about maintaining, not fixing. And that's an issue a lot of the times with the healthcare system and people with disabilities. We try too much to fix them instead of trying to help them live the way that they need to live. So next slide, please. Dr. Mitra already had this slide, but it just says that in the United States, 61 million adults have a disability, which is about 1 in 4 people. There's a slightly higher rate of disability in the southern states. In Kansas, that number is just under 25%, so still about 1 in 4. Next slide, please. So I want to stress repeatedly that having a disability does not mean that a person has poor health, but their health disparities are large. And this slide has 2 tables. The first slide is about Americans with disabilities compared to Americans without disabilities. And the second table is Kansans with disabilities compared to Kansans without disabilities. And the first table shows that Americans with disabilities are much more likely to self-report fair or poor health, and they are much more likely to self-report 14 or more physically or mentally unhealthy days in the past 30 days. And if you look in Kansas, the same patterns hold true. They're much more likely to self-report fair or poor health, and much more likely to self-report 14 or more physically or mentally unhealthy days in the past 30 days. Next slide, please. Then if you look at specific conditions, Kansans with disabilities are much more likely to have experienced a stroke. They're 5 times as likely to have experienced a heart attack. They're much more likely to experience high cholesterol, twice as likely to have hypertension, about twice as likely to have asthma. What is that? About 3 times more likely to have diabetes, and much more likely to have depression. So across a wide range of conditions, people with disabilities in Kansas are faring worse. Next slide, please. However, there's really been a paradigm shift, and I think we've heard a little bit about that today. There's an expectation among people with disabilities and their families and more healthcare providers that people with disabilities can be healthy, and they have an increased life expectancy because we have better technology, we have better assistive technology, we have better treatments, and people with disabilities are living longer. That gives them the chance to experience more secondary health problems. And those secondary health problems can actually be more serious than their primary disability, but they are preventable. And that's one of the messages I want to get across. For example, among people with spinal cord injury, the 2 most common secondary conditions are obesity and depression. Both of those are very preventable and treatable, but oftentimes they are not. And we'll hear about people's experiences with healthcare providers and why those conditions sometimes happen. As people with disabilities live longer, and as there's more acceptance and inclusion of people with disabilities, they have increased opportunities to live and participate in the community. And in fact, they have federal laws that require that people with disabilities be allowed to live in the most integrated and inclusive setting possible. And after all of that, as they live in the community and they live longer, people with disabilities have high expectations for their quality of life, and the healthcare system really needs to meet them where they are and those expectations. So next slide, please. There are so many barriers to health for people with disabilities, and I want to talk about those. And I would say, again, in this country, there are barriers for non-disabled people as well, cost being one of the main ones. But these are in addition to what other Americans experience when they try to access healthcare. And they're in 3 broad categories. The first is environmental, lack of facilities that meet accessibility guidelines. We'll talk a little bit about that. Lack of affordable and accessible transportation. We've heard a little bit about that today, and I want to talk about it some more. Lack of knowledgeable professionals, lack of financial resources. Programmatically, lack of sufficient appointment times to accommodate patients with speech limitations and other disabilities. I can say with my mother, who is elderly and is very hard of hearing, when she goes to the doctor, it takes more time just because she has difficulty hearing, and the doctor often has to repeat what they're saying, and that does take more time. And I know that there are time pressures on providers all the time to, see as many patients as you can, get as many reimbursements as you can. But sometimes providing good quality care to people with disabilities means taking a little extra time. Another big one is online systems that are not accessible, and there KU Med Center. I have a MyChart account and I use it all the time. But if I had a visual impairment and that system was not accessible to my screen reader, I would not be able to use it. And we'll talk about in a little while, a lot of people with disabilities don't have access to the internet. So those online systems are completely inaccessible to them. And to have some expectation that they have to use that system to be able to access care is a real problem. Lack of health information in plain language and alternate formats is a huge issue. Again, I'll use my mom as an example. Some years back, she was diagnosed with macular degeneration and her vision was already pretty poor at that point. And bless his heart, the doctor gave her this booklet about macular degeneration and she went to look at it and it was like 10-point font and she couldn't read it. So it's just the silliness of systems that try to do things like that, to acknowledge that you have a visual impairment and then to not have the information accessible to you. It's just an underlying problem with our healthcare system that needs to be addressed. And finally, and we'll talk a lot about this, but attitudes are huge. And there does seem to be an underlying belief or an implicit bias among a lot of medical providers that people with disabilities cannot be healthy or that the lives they live are of such low quality that their health is less important. And maybe you don't believe that, or maybe you don't think it's really widespread, but if you look at this next slide, you'll see a really striking example. So next slide, please. The coronavirus has really shined a bright light on ableism in our country. The first two headlines there, these are national media outlets, are about disability groups filing complaints about healthcare rationing plans as a result of the COVID-19 pandemic. And Kansas was one of the states where this was happening. In Kansas, it was codified that a person who relied on a ventilator or a respirator, a person with a disability who needed that equipment to live day to day, that equipment could be confiscated from them, and the need, if their need presented itself that an able-bodied person with a COVID-19 infection needed that equipment. Therefore, the lives of able-bodied people were placed above and beyond those of people with disabilities. This was taken by numerous disability groups to Health and Human Services. HHS, agreed that that was discriminatory practice, but it's still happening. The next headline down there, people with intellectual disabilities may be denied life-saving care. Again, this was codified, this was on the books, this was an official position that if there was a shortage of ability to treat people with COVID-19 infections, people with intellectual disabilities could be refused care. And I want you to think about that for just a minute. If they said, we're not going to give care to African Americans, or we're not going to give care to white people, it's the exact same thing. You're taking a class of people and saying you're denying them care, and this was allowed, and it's just really bad. And I just think that shows that we still have really ableist attitudes in our country, and they're really shining right now. And then the last headline down there, the National Council on Disability decries Hickson death. This was as recently as July. Michael Hickson was a person with, depending on which account you read, he either had paraplegia or quadriplegia, but he contracted the COVID infection, went to a hospital in Texas, and the doctor arbitrarily decided that he didn't need to have treatment. He was placed in the hospice and he died, leaving behind 5 children and a wife. So disability discrimination and ableism is a thing, and it is happening in our healthcare system. And one other thing I would note here when we're talking about the coronavirus, I think someone mentioned it before, but from a legal standpoint, if you're a person with a disability and you're admitted to a hospital because of a COVID infection, you are legally allowed to have an assistant be in the hospital with you, even though most hospitals are not allowing visitors during the pandemic. Legally, a person with a disability is allowed to have someone if they need that person to have better communication or to assist them with things that the hospital may not be able to. So that's also not been happening for people with disabilities. There's been many incidences of where their assistants have not been allowed in and they have not been able to get the things that they need. So just by way of an example, a timely example of where we are in the healthcare system and attitudes about people with disabilities. Next slide, please. I'm switching gears a little bit here, just going back to other barriers to accessing healthcare for people with disabilities. And I think in my bio, it said that I like to give voice to people with disabilities. These are actual quotes from Kansans with disabilities who are enrolled in the Kansas Medicaid program called CanCare. CanCare is administered by 3 managed care organizations, 3 private insurance companies. So if they mention MCO, as you'll see below, that's a managed care organization. Medicaid is federally required to provide NEMT, non-emergency medical transportation to people with disabilities who are on Medicaid so that they can get to medical appointments. However, that doesn't mean that it always works well for them. And I just wanted to give you some context of why people with disabilities may be late to appointments or why they may have difficulty accessing healthcare, even though this transportation is theoretically available to them. First person says, when I could use the transportation, they ran late a lot. Now I don't use it. I can't use it because they changed their policy. They only allow 1 adult and 1 kid in the taxi. I have 2 younger kids, 1 with autism. I can't leave them home alone. So even though the person was wanting to use that transportation to get to medical appointments, the rules around it were not facilitating that process. Another person who used a wheelchair, the transportation people don't transfer me correctly and I've gotten hurt. So that's a big disincentive to using the transportation service to get to the doctor because you're getting hurt in the process. And finally, my doctor's office changed my appointment time, but the MCO won't change the pickup time because it is not 3 days notice. And I think that's true across all 3 of the MCOs in Kansas. You have to set up your appointment at least 3 days before. And I know, again, as a patient at the KU Medical Center, sometimes appointments get changed at the last minute, the day before or even the day of. Can you come in 2 hours later? Can you get here 2 hours earlier? Such and such has surgery. And most of the time, people out there in the community can accommodate that, but people who are relying on this service to get their ride cannot. And it makes it that much harder for them to get in and to see a provider when they need to. Next slide, please. And again, more quotes from CanCare participants about just coverage issues that they encounter on a day-to-day basis. This first person says, the MCO will not pay for portable oxygen concentrator that I need to be able to go for walks. I need to get exercise to control my diabetes. Well, here's a person with a disability trying to take care of themselves, trying to participate in some physical activity to improve their health, and the insurance is not facilitating that process. They're not getting the equipment that they need to be able to go out for walks. So I can just see that person going to the doctor and the doctor saying, well, why aren't you exercising like I told you to? and it's part of the reason is because the insurance is not facilitating that process. The second one, the MCO cover catheters, but the gel for catheter insertion is no longer covered. It's only $5 or $6 a tube, but it makes no logical sense. This one to me is very powerful because I had a friend and colleague with spinal cord injury who self-catheterized, and she got multiple UTIs and eventually died from complications of urinary tract infection. So being able to insert a catheter in the correct way is really important. And for insurance not to cover the simple cost of the lubricant to do that, to me is unconscionable. So it's one of those really short-sighted things. Let's save a few dollars up front, but we're going to pay for it at the end because someone's going to get much sicker and require a lot more care. And finally, the last one is kind of like that too. I use a wheelchair and get pressure sores on my feet. My doctor says I need a shoe insert to stop the sores, but it's not covered. So I wait until it is more major and go to the doctor or hospital repeatedly for them to fix the aftermath. And again, I can see, a doctor telling their patient, well, why didn't you get this insert like I told you to? Well, if you can't afford it and the insurance doesn't cover it, then it really is. It becomes a reactive system where you're trying to clean up after the fact instead of, preventing some of these conditions that are very preventable. Next slide. So that's some of the barriers, transportation barriers and coverage barriers, but I want to look at some other barriers that people with disability experience. We talked about the fact that people with disabilities are much more likely to report that they didn't need medical care due to costs, so about 3 times more likely than the general public. Women with disabilities are much less likely to be current with mammograms or Pap tests than women without disabilities. I don't know specifically, but I can venture a guess that part of the problem is accessibility of equipment to get both of those tests. Dot can talk about personal experiences when she talks, but many cases you have to be able to stand up to get a mammogram. If you can't stand up, that's a real problem. Similarly, if you need to get a pap test, you usually need to be lying down on an exam table. If the exam table is not accessible, I'm pretty sure it would be really hard to get a pap test sitting in your wheelchair. So yeah, it doesn't happen because the equipment is not there to support it. And among the resources that we provided that Alexa has was a recent publication from 2020 on colorectal cancer screening among people with spinal cord injuries. That was authored by a recent PhD graduate from KU Med Center. And the patients that he interviewed were patients at the KU hospital system. And I encourage all of you to read it, and just, it's jaw-dropping the kinds of barriers that people with disabilities experience when they try to get the same care, the same preventive care that other people get easily. Going on our list here, people with disabilities are much more likely to be victims of violent crime, which obviously has implications for their physical and mental health. People with disabilities are much less likely to report getting sufficient social and emotional support, and I suspect that those numbers have gotten worse as a result of the pandemic. People with disabilities are much less likely to be employed, and that's important for many reasons. For one thing, they don't have much income, and you can see the last slide here. People with disabilities are much likely to live in families that have income below the federal poverty level. But working is also really important for self-esteem and feeling like a productive citizen and getting out there and being able to socialize with people. And that really abysmal employment rate has not improved much, even after passage of the Americans with Disabilities Act 30 years ago. It's something that I think we as a society really need to continue working on. One thing good that has happened, a lot of people with disabilities are saying now that for years they tried to get their employer to let them telework, and it was always refused as a reasonable accommodation. But now it seems like people are starting to understand, hey, maybe that really was a reasonable accommodation, and that's happening for some people, and that's a good thing. At the same time, though, if you look at that row there about internet access, people with disabilities are much less likely to have home broadband. And I think that's true, especially in parts of rural Kansas, especially. And that's a problem, again, if you are relying on patient portals to get information, and in many cases now telehealth appointments. If that's contingent on having a broadband connection, a lot of people with disabilities are not going to be able to do that. So on the one hand, telehealth could be really important for people with disabilities because it addresses that transportation barrier. But on the other hand, if it requires a broadband connection, it may not solve the problem for a lot of them. Okay, next slide, please. So I want to kind of switch gears again and talk a little bit about actual interactions of people with disabilities with medical professions. And this is from a report, again, by the World Health Organization. So there, I think we've seen now that there is persistent social stigma associated with people with disabilities. And I do think that that infiltrates patient-physician interactions, whether it's, overt or covert or if it's unconscious or not, it does happen. And as a result of that, people with disabilities who've had negative experiences with the healthcare system, such as experiencing disrespect, insensitivity, or devaluation, may not seek care. And I think Jeff mentioned that kind of sets up this negative feedback loop where people don't get the care they need when they need it. And then when they go, they're being disrespected, and it's a terrible situation. And another paper that we included in your resources is a paper that I just recently authored with some co-authors this year about the experiences of people with autism spectrum disorder, many of whom are also LGBTQ. And the biases, explicit biases that they experienced in the healthcare system led many of them to either not disclose their disability or to just not go to the doctor at all. So it's a thing. It's something I think we all need to work on. And hopefully that's something that we can overcome. I can tell you, related to that, people with autism spectrum disorder, when they tried to talk about their sexuality with their providers, some of them were told that because they had autism, they couldn't possibly understand their sexuality. So again, it's just really some attitudinal barriers that need to be overcome. Physicians lack the expertise and skills to distinguish clinical concerns arising from disability from those related to other health conditions. I think this is called diagnostic overshadowing. And I just recently reviewed a manuscript. It hasn't been published yet, but one of the case studies in there was a person who used a wheelchair with a spinal cord injury. And 5 separate times he went to the emergency room or to his doctor because he was losing weight and didn't understand why he was losing weight. And 5 different times he was told it was just gastric paresis due to his paralysis and it was nothing to worry about. And finally it got to the point where it was life-threatening and he went to the emergency room. They did some tests and they found out that he had a very large tumor that had metastasized at that point. But there's just this assumption that whatever is wrong, it's attributable to the disability, it's part of the disability. And I don't know, I think that is a training issue that needs to be overcome. And I hope that hearing stories like that can make a difference. Limited knowledge and understanding of disability can affect the quality of care and diagnosis and treatment. So next slide, please. This is what some actual research that's been done to clarify some of the points on that previous slide. So physicians are significantly less likely to ask their patients with disabilities about their smoking habits. So, most places you go, your doctor will ask you if you're smoking, if you'd like to have smoking cessation. It's routinely not asked of patients with disabilities. And I would say the same thing is true about asking about exercise and physical activity. Maybe doctors feel like they can't ask their patients to use a wheelchair if they go out and walk, but they can ask if they go out and roll. They can ask if they have other ways that they're getting physical activity because it's just as important. As I mentioned, obesity is one of the most prevalent secondary conditions among people with disabilities, and it needs to be addressed just like it would be for anyone else. Another problem around that is that many doctors' offices don't have roll-on scales, so they might not know how much their patients with disabilities weigh, and therefore they might not know to be talking to them about weight loss. Quality of patient-provider interactions were significantly poor for people with mental illnesses and people on Medicaid. One of our speakers earlier today talked about the fact that as soon as some of her doctors knew that she had a diagnosed mental illness, all of a sudden everything that was wrong with her was attributed to the mental illness. I think there's probably a grain of truth. I mean, this is research that's been shown, but something clicks in a provider's head that, oh, well, they have a mental illness, that's what's wrong with them, rather than realizing that, oh, they actually sprained their ankle and they need to be treated. So it's really important that providers be able to step back from the disability and see the whole person. We've heard this mentioned already, the third bullet, physician adherence to sexual health guidelines, such as questions about sexual history and menstrual regularity, are significantly lower for patients with disabilities. I do think that there is a tendency among many people, not just medical providers, to think that people with disabilities are asexual. It's not true. They need the same education and information as any other person or patient. We did a study, it's been a while back now, but we found that 80% of youth with disabilities had never received sex ed education in school. I don't know if they were segregated into different classrooms or maybe their whole school didn't have it, but many of them intended to have children when they grew up, and they weren't getting that information. It's a real problem. And finally, physician concepts of disability can be very problematic. So here's some actual quotes about what doctors said. Disability is where they are completely dependent on somebody, like a caregiver. And they use words like wheelchair bound and suffering from a condition. And actually, I heard earlier today, and I don't know the exact context, but someone said afflicted with disabilities. That's a very value-laden term to use. Most people with disabilities would say that they experience a disability, not that they're afflicted with or they suffer from. So I would encourage you not to use language like that because it really paints the whole flavor of your next interaction. And last slide, I know I'm running out of time. Next slide, please. We have a program called the Kansas Disability and Health Program in one of 19 states that are funded by the CDC. We're working to address these issues. We're trying to provide continuing education through the Area Health Education Center for currently practicing medical professionals. I'm working with people with disabilities. Some of our previous sessions are, I believe, available out there for listening to in CEUs. We are trying to work with medical school curricula to reach first and second year medical school students through Enrichment Week. We had 40 slots available. We had one filled. The one student who did take our class said it was great. He wished that every medical student had information about working with people with disabilities. We found out that the simulation lab at KUMC, when they, on the rare occasions, have a model patient with a disability, it's an actor portraying a person with a disability rather than an actual person with a disability. To me, that's unconscionable again. The actor cannot possibly know the lived experience of the person with a disability that they are portraying. I think that's a real problem that needs to be addressed. When we visited the simulation labs at the Med Center campus, we found that they were inaccessible. The exam tables were very high. You had to step up on to get to them. And the computer monitor where the physician or medical professional would enter information was set up in such a way that they had to have their back to the patient. So if it was a person who had any kind of communication issues and needed to see the provider's face to talk to them, it wouldn't have happened. So I think there's a lot of work that can be done at the medical center campus and in their simulation labs. I think it's really important for physicians and other professionals with disabilities to join the field because they then can understand the experiences of their patients with disabilities. We are conducting CHECK assessment, which is Community Health Environment Checklist, where we are working with Centers for Independent Living across the state to assess the usability of health facilities. And if that's something that you're interested in, we can pair you up with the center to do that. And also we think it's really important to teach self-advocacy, healthcare self-advocacy to people with disabilities. So in case they do encounter one of these doctors who talks down to them, they can advocate for themselves. So I'm going to stop there because I know I'm over time.
According to my schedule, it looks like you're just a little bit ahead here.
Oh, good. Okay.
So you want to take a deep breath and expand for a moment or two?
Sure. I would like to. I really, really hope that people on this call, people on this symposium can talk to people at KUMC about including disability in the curriculum, not just during a special enrichment week where people can voluntarily sign up for it, and to really include people with disabilities as model patients in the simulations, making sure that accessibility of equipment is stressed. And that's going to maybe talk about some of her personal experiences with accessible equipment at KUMC. But I just think that until medical school students are exposed to those concepts, there's no way for them to get it. And if you guys can tell me someone to work with, I would gladly do it. But I just think there needs to be a paradigm shift at the Med Center as far as embracing these ideas about how to be more inclusive of people with disabilities.
Thank you for that, that offer. I'm pretty certain that at least a few of us are going to take you up on it.
Okay, good.
Dot, are you ready to do your presentation? That'll give us a little bit of extra time for question and answers at the end.
I'm ready to go. Can you hear me?
Yes, but I got to introduce you.
Okay,
Hang in there.
go for it. Don't read all that.
Let me do a quick abbreviated introduction. Dr. Dot Neary received her doctorate in developmental and child psychology from the University of Kansas and is an assistant research professor at the Research and Training Center on Independent Living at KU. Her research interests, her advocacy, and her leadership at our university and in our community has been instrumental in promoting disability awareness. And I've known now Dot for years, and I will attest to her ability to enhance one's understanding of the disability world. I have learned more from my conversations with Dot than in reading textbooks, almost a guarantee. I'm happy that she chose to speak with us, and I introduce you to her now. Dot, go ahead.
Thanks, Jeff, and thanks, Dr. Hall, and thanks to the symposium organizers to inviting me to speak today. It really is an honor. I'm fortunate to represent the Kansas Disability and Health Program and to do work that I'm really passionate about. I want to give you some relevant background. I was born with spina bifida. I was able to walk until age 30 when an undiagnosed tethered spinal cord became problematic and I began using a wheelchair. No medical provider recommended that I use a wheelchair. I just decided that being exhausted all the time, falling frequently, and dealing with infections and toe amputations due to pressure ulcers on my feet with no diagnosis was not working. Using a wheelchair gave me my life back to do things that I had given up. I didn't go through a rehab program, and my effort to learn to use a wheelchair on my own was not without mishap. I literally got thrown out of my chair a few times in learning to negotiate bad curb ramps and other barriers. And believe me, there is nothing like the experience of having to be picked up from the ground and plopped back into your wheelchair to teach humility. These experiences taught me to be more careful, but they also made me realize that the world did not accommodate people with disabilities, and that if I didn't learn advocacy skills, I was raised not to question the doctor, to do whatever the doctor said. I had to learn to advocate, and I had to do my part in changing the world, or life would be very difficult. So that was an early lesson. This was just a few years before the Americans with Disabilities Act was passed into law, and my personal quest for equal rights was validated by my participation in a national movement to pass a civil rights law for people with disabilities. This experience has forever influenced my expectation of equality as a person aging with disabilities, including a recent stroke. It also influenced my choice of careers as I pursued a doctorate and balanced roles as a disability researcher and as an advocate. And I just wanted you to know that, to see where I'm coming from with this presentation. So today I'm charged with discussing resources for clinicians on the topic of addressing health disparities. I've done that through a list of health resources that are provided in the conference materials. But let me say first that one of the best and most comprehensive resources is the book I have here. It's called More Than Ramps, A Guide to Improving Healthcare Quality and Access for People with Disabilities. And again, it's in the resource list. It's written by two researchers with disabilities, Lisa Iazzoni and Bonnie O'Day. It was published over 10 years ago. But unfortunately, while some of the data may be old, the problems that it presents still persist. So that is a wake-up call to all of us. But beyond resources, I want to take a few steps back to ask some questions, and I hope raise a discussion that goes well beyond today's event. I want to amplify Dr. Hall's points and some of the other points that have been raised by the great panels earlier today, and explore further why stark health disparities still persist. I don't have answers. I have questions. They go well beyond the minimum standards of the ADA and speak to our basic perceptions about people with disabilities. Next slide. So this is a slide with a graphic, colorful graphic of people non-disabled and disabled, and it says disability is a fundamental element of diversity, inclusion, and equity. I want to ask, do we really regard disability as a bona fide issue of diversity, and not just as an issue for a symposium, but in our daily work and interactions? I find that disability is often left out of lists of diversity issues and on diversity panels, so I congratulate folks holding this symposium. I live in Lawrence, and I see signs around town that say, have a list of diversity issues. Black Lives Matter, women's rights are human rights, all humans are legal. All important issues, but I never see disability included. I have not seen that once. So again, I have to ask, why is disability often left out of diversity efforts in the larger community? Next slide. So if disability is not included as an issue of diversity frequently, what is the reason? Everyone involved in this event, including myself, is a member of multiple communities, not just the healthcare community. I want to share a quote from Kim Nielsen's excellent disability history that may provide some light for this question. When disability is considered to be synonymous with deficiency and dependency, it contrasts sharply with American ideals of independence and autonomy. Thus, disability has served as an effective weapon in contests over power and ideology. For example, at various times, African Americans, immigrants, gays and lesbians, poor people, and women have been defined categorically as defective citizens incapable of full civic participation. So, has this perception of people with disabilities as defective citizens not been fully abandoned? Does it still persist with those charged with providing care to help us, people with disabilities, to be healthy and functioning? So again, I'm probably not going to provide answers. I'm going to ask a lot of questions that we can all think about. Next slide. This is a quote from the World Health Organization. It shows a person in a power wheelchair butted up against a set of steps. And it says, disability is now understood to be a human rights issue. People are disabled by society, not just by their bodies. So I have to ask, has the social model of disability been fully accepted by healthcare providers? A model in which disability is accepted as a common human experience, in which the problems lie in environments and attitudes that do not accommodate disabilities. I think this is connected to the concept of unconscious or implicit bias mentioned by several presenters earlier. I have to ask this question because of the experiences that have been mentioned today and that we all hear about too often. The person with anxiety and panic disorder who's admitted to the hospital and is treated differently as soon as the staff reviews the medication that she takes, echoing Stephanie West Potter's earlier statement. The patient with a spinal cord injury who attends a medical appointment and is not provided the standard care of having her weight measured as no accessible scale is available or it is in disrepair. This had happened to me last week at KUMC, but it's not as bad as the time at another facility where I reported for an abdominal scan and was asked, why did the doctor order this test if you can't get up on the table? So I was the problem because I couldn't get up on the table. The problem was not that they had bothered to get an accessible table. The blind patient who was told that she must bring someone with her to complete registration forms for an appointment because the staff simply doesn't have time to assist her. The person with an intellectual disability who is not addressed directly by the healthcare provider, but rather is ignored as the provider speaks to the person accompanying him, an issue previously mentioned today by Stephanie Coleman. The deaf person who must struggle to communicate with the provider using written English, which is a foreign language with her in the absence of an interpreter. Or maybe one of the worst in my mind, the parent told upon the birth of a child with a severe disability that they should simply put the child in an institution. Yes, these situations are still common 30 years after passage of the ADA. And in keeping with the social model of disability, are we all aware that when a group asserts their civil rights, that they also shape the language that is used to describe them? Are we still using phrases like mentally retarded, confined to a wheelchair, or even the word normal, which can imply that people with disabilities are abnormal in some way? As Chris Johnson mentioned earlier, language matters. And in a little plug for the Disability and Health Program, there is a guide to disability language in the resources. But we need to think about how we think about disability because it's reflected in our behavior. Next slide. This features Justin Dart, who is a hero of the disability rights movement. He lived with polio and did a lot of work on his own dime to travel around the country to promote the Americans with Disabilities Act. And he said, disability is used to signal the end of an active life. Now it is a common characteristic of a normal lifespan. Sooner or later, it will occur in the lives of most people, surely in the life of every family. And in the back of Justin Dart in the photo, he's speaking at a rally in front of the US Capitol in Washington. Injustice anywhere is a threat to justice everywhere. And that's a quote from Martin Luther King. And I think people with disabilities experience this phenomenon acutely. I'd like to go to the final slide, if you would advance a couple, Alexa. Can you go back? This one. Actually, no, go to the one before that. Okay. Oh, no, go back to Harriet. Sorry. I changed these around last night. I think it's important to, I'd like to give this quote from Harriet McBride Johnson. She was a disability advocate, a lawyer, and an author who debated Princeton bioethicist Peter Singer about his belief that parents ought to be able to euthanize their disabled children. So let that sink in for a minute. She wrote, "The non-disabled world tells disabled people generally that our lot is unavoidably tragic. And if we're smiling through tears and despite suffering. In the face of these powerful social forces, I believe that living our strange and different lives, however we choose and manage to live them, is a contribution to the struggle. Living our lives openly and without shame is a revolutionary act." So I guess I have to ask, do we view people with disabilities as tragedies or as revolutionaries? Because that certainly will impact the way we provide care, the way we interact with people, and the way we embrace their goals for living. And for me, that is to live in the community as long as I can, because if I can't live in the community, I really don't want to live to 100. I want to remain in my environment, and that's really important to me. So I think I've given you some things to think about in your various roles as administrators, as educators, as clinicians, as students, as support staff. You know, I found in a month-long stay at KU Med that the person who came in to clean my room was a ray of sunshine every day. And her role in my recovery was really, really important. So I think we need to look at the whole experience when a person with a disability comes for healthcare, whether it's the receptionist, the nurse, the doctor, or the person who may make sure the room is clean for that person to come into. So I've given you things to think about in your various roles as participants in large and often impersonal healthcare systems and as future providers in other systems. I think also we need to think about when a person has a difficult experience in a healthcare system, who do they report that to and who listens? It's really hard to find information about where to provide feedback to the med center. And I think that is one thing that could be addressed. Because I think for most people, digging through a website page after page is not a good way to be able to get give some feedback and get some response to it. So I'd like to leave some time for discussion, and I want to leave you with a final question. Giving you the information I've shared, given the experience of people with disabilities and of providers who are in tune with people with disabilities about experiences, what is the role of the healthcare community in eliminating health disparities experienced by people with disabilities? I'll leave it there.
There are an amazing number of questions in the chat, and I can't possibly begin to pick one. I think what we can do is have people respond to your last question. I think that is a good launching place. So if our audience has something they'd like to voice, raise your hand in the reaction button, and Alexa or I will call on you. Go ahead and speak. I would really like to hear what people have to say.
I've left everyone speechless.
I'm actually on the phone and I don't know how to do the reaction button, but if I could ask a question.
Please, go ahead.
My name is Carol Lujo. I'm a neurologist, and that was just an amazing talk. I actually had put the question in the chat, and that is, any comment in particular for patients whose disability is not seen outwardly? Meaning it is not, a physical disability per se, but maybe something like, in my case, I see a lot of patients with epilepsy, and that affects their employment quite a bit.
This is interesting. Years ago, I participated in a program with some voc rehab counselors called Windmills, I think it was. And everyone was asked to, given a variety of disabilities, and asked if they had to have a disability, which one would they choose? Almost all the non-disabled people chose epilepsy because they felt it wouldn't show and people might not know that they had it. So, which was shocking to me because I know people with epilepsy and I know what they live with. And sometimes it's just the fear of having a seizure and your whole life is turned upside down. So I guess I'm not a person with epilepsy. My disability is very visible and in some ways that's fortunate for me. But I guess maybe providers can steer people toward peers and help them understand that maybe acknowledging their disability when it's possible might be an area of strength. And I know that's difficult. I'm understanding all those difficulties, but that maybe a peer might be a good way to help people cope.
I would like to throw in, this is Jean, as a person with multiple autoimmune conditions and invisible disability. The provider attitudes are not necessarily that much different. When I was in my 20s and fairly newly diagnosed, I went to go see orthopedic surgeon, and the nurse was taking my history, and she asked me about my medications, and it was a pretty long list of medications. And at the end, she said, well, gosh, if I had to take all those medications, I think I'd rather just die. It's like, oh my gosh. Thank you for telling me how much my life is worth.
A little sensitivity training, maybe.
Yeah. So it's just, I would say that people with invisible disabilities can get some pretty crazy feedback from the medical system too. And I do, maybe it's different, but Dot was talking about her experience with the Windmills program. I was in another group and people were asked which disability they would be the most frightened of having. And that was blindness. And with a little bit of discussion, the fear was that they would be dependent on other people if they were blind. So like there's this whole, mindset that it's terrible to be dependent on other people for some reason when we should all be interdependent on each other, I think. And it's funny to me because I have known and worked with a lot of people who are blind, and they are the most fiercely independent people you can ever meet. So it's people's perceptions are just kind of wacky sometimes.
I want to allude to a point Jean brought up before. I remember sitting with a doctor years ago, and one of the things he was recommending with exercises, but then he looked up and he said, well, I don't know what you could do. Which I think things are changing, and I hope providers are more aware of what people with disabilities can do. But I do know also that the National Center on Health and Persons with Disabilities has actually a prescription form for exercise to raise provider awareness that exercise is for everyone. So I think there is work being done, but boy, we've got more to do.
So lots of questions and stories and things in the chat. Tracy, did you want to expand upon your experience with your husband and just the understanding of what doctors have to say? Is Tracy here?
Yes, I'm here.
There you are. Hello.
Probably more the problems we see, and I have to say it's more in some of the areas such as, I would think more cancer type related. We've had some cancer along with the MS. There's a lot of big words, and I know as a therapist, we say those words, but we've really got to bring that education level down. Because I think as we talk and start saying things, I know that he loses things very quickly. and then just basically will shut down and nod his head, yes, he understands. So I think coming back, like you say, and having people repeat what they hear and understand is helpful. I know, and I can't remember what level it's supposed to be, what a fifth grade education level. Sometimes just the way we talk to people and what we word it needs to change. A lot of times I always try to go so that I can then turn around and explain it back at home. So having that person with you is pretty important. I just think that, and also the time that we mentioned, when you talk really fast, the language gets lost very quickly. And I know in our healthcare, we are in such a hurry sometimes because schedules are so busy, but we do lose things very quickly when you talk fast.
Mhm.
The other thing, the gestures and just, I think more understanding comes if you come in and sit down, put yourself on that level with the patient. I think there's a little bit better understanding than when somebody's looking over you. Just all of those things I think help. But a big part of it is with some of the kind of the comprehension and the understanding. It's probably that clear speech. I don't know how we solve sometimes with the strong language barriers. A lot of physicians have very strong accents, and that's very difficult for patients to understand, and they don't want to hurt feelings, so they just shut off. And that to me, that's a little bit difficult one to solve. I guess I would throw that back. Not that there's just different languages, Spanish, different ones from different areas that are so strong. How do we nicely not hurt a physician's feelings, but when you can't understand that strong accent, what do you do?
Tracy, this is Jeff. On the university side, the Board of Regents requires instructors to pass a English competency and English, understandability test in order to teach, in order to be GTAs. I don't imagine that's something that could be applicable in the healthcare environment, but it is a recognized problem that if you have, for good reasons, a challenge with communication, how can you actually be effective in communicating?
Well, and I do think it really is important getting back to self-advocacy for people with disabilities. If it's important to let people know that it's okay if you don't understand something to be asked to be told again. And I know that people get shot down for doing that, but that you just have to keep fighting for your rights. So I think it goes both ways. It really is important as a person with a disability that you speak up if something's not right.
I think self-advocacy is an essential life skill for people with disabilities.
And I agree. That's where I have to come in sometimes and really help to self-advocate. On our side, mine tends to kind of back away and he's not very good at doing that. So that's usually why I have to always be there to kind of help that, kind of promote that conversation a little bit. I do like that KU is using a lot of nurse practitioners and PAs, or a nurse that comes in with those physicians. And it seems like they've typically been people that help to make it more understandable. So it's kind of nice to have that second support system with some of the physicians maybe that do have a little bit harder tone to understand. They usually have somebody with them to help, and that is very helpful.
I also think it's a really key component of any kind of physician or medical training program that we're doing for communication. And it doesn't need to single out the person who speaks with a heavy accent or uses English as a second language as a healthcare provider. If we're teaching all healthcare providers as a part of our interaction to say to every and all patients, if I explain something that you don't understand, please let me know. That takes 2 seconds to say. And it creates an environment of hopefully better or good communication, and doesn't put all of the onus on the receiver of care to, yes, we have to self-advocate, but communication is not the responsibility of one individual in the room, ever.
Good point.
Ryan, this is Moya Peterson. And thank you, Tracy, for plugs for nurse practitioners. I am one. And I think I teach a class on disability to nurse practitioner students as an elective. And I also teach periodically in the clerkship for the third-year medical students in family medicine. And I think what strikes me every time I do this is that if I ask them what caused this disability, they can all tell me. How do you treat that disability? They can tell me, but they have no idea of how to relate to them, or the social model of disability, or the versus the medical model, or they have no idea about any of that and how to relate to them as a person. And when I talk about disability language and not saying wheelchair bound, that's all new information to them. And they're only a year, the medical students are only a year or a little more away from practicing. And my nurse practitioner students are only maybe a year away from practicing. And it worries me that none of this has been dealt with in the curriculums prior to that hour that I spend with the medical students, or prior to the semester that I spend with the nurse practitioner students. So we are very behind in our education, and just making sure that primary care providers understand what it is to take care of someone that maybe can't communicate, and you have to listen. I have lots of patients that have cerebral palsy, and I have to work very, very hard to understand what they're saying, and it takes time, and it's just a different approach. And I think we're doing a not a very good job helping our medical people be ready for those kind of things in their practices.
I just want to make one point. One of the slides I didn't show was from the first annual Stanford Conference on healthcare providers with disabilities. It was held in June, and one of the doctors who became disabled in medical school and is now practicing, it was a great quote noting that providers just don't get training in working with people with disabilities. There's just not enough information. And from him seeing it from both sides of the coin, he gave a great presentation. I hope that I put something in the resources on that conference. And I think it would be good for anyone to log into next year. I hope they do. I think it's an annual event. So.
And I would point out that's actually progress, because Lisa Iazzoni, who is a physician with a disability with MS, many years ago, she was, I believe, in Harvard Medical School and was diagnosed with MS. And the assumption was that she just simply could not be a doctor anymore because she had MS, and she was offered a research position at 1/10 of the pay that she would have had as a physician. And she's gone on to do amazing things, but there was just an automatic assumption at that time, some years ago, that because she had a disability, she couldn't possibly be a physician. So yeah, we're making slow progress.
There are a lot of comments in there about the need for learners to be able to have these conversations, learn how to interact with various individuals of all experiences, and lots of people saying, yes, please, yes, please. So that's definitely going to be a big takeaway from today.
Well, and we need to have those model patients that actually have disabilities instead of actors portraying people with disabilities, which it just still blows me away.
Representation. I just saw Barb had a really good comment about how challenges create things being lost in translation, and many individuals avoid going to doctors because they feel like they're not being heard. How do we stop that? How do we change that? What can we, besides everything else we've talked about, are there other things that can be done differently?
I think it would be really helpful for any kind of written or web-based materials to include images of people with disabilities, to include welcoming statements that indicate that you have sign language interpreters available, you have alternate formats available, you have accessible scales, you've done an accessibility check of your facilities, you welcome patients with disabilities. if you have a particular provider who's especially comfortable working with people with disabilities, it doesn't hurt to put that out there. Things like that. I think just really being proactive and saying that you are aware that some of your patients have disabilities and that you look forward to actually working with them would be helpful. You have to be welcoming.
This was also my one point with asking about care coordinators. I am really impressed with, we had shared solutions. My husband has a medicine Copaxone that comes from them. They have a nurse that would reach out monthly and give my husband a call. So it was just him and that nurse. So I'm not part of that conversation, which is really nice, but they would speak to him and ask about how things are going, other issues coming. So they were a very nice guidance to help him solve issues that he was dealing with himself. So that was also my question towards a sister-in-law who has currently, oh my gosh, probably 10 consulting services for all kinds of issues that just came up. She's not in the KU system for primary, which I'm going to help her do, but I think a care coordinator for such complex cases that have so many things is a wonderful thing because they deal directly with the patient and dealing with the issues that they're having and help guiding them to where to go next or where to get those answers. And it's a one-on-one, very comforting. We've had some very good nurses. So I highly encourage that. That's been very helpful.
I had a similar experience. I was taking Humira, and I had a nurse case manager assigned to me while I was taking it. The problem was as soon as I stopped taking it, I was gone. They didn't care anymore. So it was nice while it lasted, but yeah, it has to be something that is separate from contingencies like that, that's more broadly available.
That's why I wish maybe if going through the, if you do have that primary care, or I don't know if there's a way to help because there's just so many consultings coming that it gets too confusing for people when you have 5, 6, 7 different services. And I see that as a caregiver. I have a hard time when I'm working with my patients and I have, 6 different neurology, ENT, I have ortho and burns, I have everybody coming and everybody's talking, but there's no guidance in the middle to put it all together. So I just think that is such a wonderful role. And I hope we someday get more of those and keep it going. Yeah.
I just saw the comment from Dana Reinert that they have a complete website redesign and process at the Med Center, and this creates a great opportunity to improve. Yay, that's awesome. I really encourage you to do that. And again, if we can help, I'd be happy to do that.
Very good. We had another interesting comment from Kathleen Davis, and she wrote, K-12 teachers worry more about having a student in their classroom with epilepsy than any other diagnosis. I was wanting to see if she could elaborate on that comment. Nope. Okay. We have another question. Carol Uola asked, any comments from the speakers in regards to disability that are not seen outwardly but affect employment, such as epilepsy?
Oh, that's yours, Dr. Hall.
So the Americans with Disabilities Act does apply to invisible disabilities, but the problem or the issue is that if you need an accommodation, it's incumbent on you as the job applicant or the employee to request the accommodation. So it's really important to know what you need to be able to do your job, because chances are your employer is not going to try to figure that out with you necessarily if you come to them with what you think that you need. And oftentimes, and it's completely allowable for them to request medical documentation, so be prepared with that as well. It can be a really intimidating process. I've done it, I've had to request an accommodation before, and it can be scary. So if you can get an advocate, for example, with the local Center for Independent Living, that's helpful. and just knowing what it is that you might need or how to explain that to an employer and practicing it can be very helpful too.
This is Moya again. I work with adults with Down syndrome, and it's always amazing to me what parents and caregivers, the letters they ask me to write. And my favorite one is when I get forms that want to know how long has the person had this disability after I've told him he has Down syndrome, and about how long will he have it. And I have to write letters to say that I don't think they'd be particularly good at jury duty. And someday I'm going to let them go. And
Yeah,
because they love everybody, and let them go and let the court decide whether or not how long they've had it and when will it get better and if they could serve on a jury. But it always amazes me what letters I'm asked to write.
Along the same lines, we had a comment earlier from Leslie. She wrote, at 6 months pregnant, I was told my daughter had a 1 in 3 chance of having Down syndrome. Their immediate response was to schedule me for an abortion. This was 14 years ago.
oh,
Yeah.
Yeah, that was me, and I'm still upset about that because it was like a 2-day process. I had told them from the beginning that since I was 36, they said, we're going to run these tests. And I said, I don't care about the tests. I don't care about the disability. If the child has a disability, I'm going to have this child. And they sat me down in a room with a bunch of, people with way higher educations than I had. But their first, they are explaining to me, okay, well, this is the test that was run. This is the probability. This is going to have a 1 in 3 chance of having this disability. And if we're going to do an abortion, we need to do it immediately. And I was just flabbergasted because here I am telling him, everybody, this isn't going to make a difference. I don't want the test run. If the test comes back, I don't care what they say, I'm still going to have this child. But the good thing out of it all was when she was born, the very first thing that one of the nurses said to me was, congratulations, you have a child with Down syndrome. If you have a child with a disability, this is the easiest one to deal with. At least she was born too, because they treated me like she had died. You know what I mean? Like I didn't get the same like nurses and stuff in there all the time checking on me and making sure I was okay. I was left alone. Like I was left alone to grieve, which it's a process. You do grieve, but that doesn't mean I wanted to be in there by myself. They transferred her immediately to Children's Mercy, and I was in the hospital for another day. And then when I got to Children's Mercy, I had the nurses looking at me like there was something wrong with me because it took me a whole day to get down there to her. So I really think that there's a whole disconnect in education about disabilities and how to treat people that choose to have, to go ahead and have the child, knowing that the child is going to have a disability. I just can't believe it's still happening.
One of the most important things I think in that situation is to have a parent of a child with Down to come and talk with you. I think peer interaction and peer counseling is so important. For anyone newly diagnosed with any condition or parents of people, a child born with a disability, it's so important to know that, everything will be okay and this is how you get through it and this is what you can expect. And rather than just to leave you sitting there by yourself, to me, that's unconscionable. So yes. And that's really an important part of independent living is peer counseling and talking to others who have your condition or have experienced things that you do so that you can see that there's a way ahead.
Jean, I appreciate you saying that about the peer counseling and having that support. I also just want to comment on what Leslie shared as far as just the very obvious conscious bias against a person with a disability and assuming there's this belief system put on others that somehow having a child with a disability is wrong, that you wouldn't want, that baby wouldn't bring you joy. And it's such a negative attitude. And And Leslie, I experienced that as well when I was pregnant at 40. And I just think it's unfortunate that it's so pervasive within the medical field. It was the medical providers, all of whom that were forcing their negative views of a person with a handicap on me and trying to convince me that it would be a bad thing, a bad experience to be a parent of a child with some sort of handicap. And as you said, I mean, I'm not a medical professional. I'm not as educated as the people who were talking to me and trying to convince me, but I did know something about love. And I knew that as a mother, as one who loves, that their education didn't matter in that type of situation. And at the time, I didn't have the words for unconscious bias. I didn't know how to say that or share that. And I love being part of KUMC as it gives me the education and the experience and the exposure to be able to unpack these experiences and understand what they are. I just knew that what I was being told was inappropriate to force other, another belief system on me as a mother and kind of a vulnerable position.
Just one more comment. A group that I am in, the Dot Friends, we all have kids with Down syndrome. We live in Wyandotte County. It's part of the larger group of the Down syndrome group. But one of the other ladies in my group, their doctor told them when she was pregnant with them that the baby would be crazy as a loon, and she didn't want to have to raise that child. So that was even though mine was bad, I kind of feel like that was just as bad, if not worse, to have from your medical provider, to tell you that.
Thank you
I will
both
say
for,
that I think that the good news, this is Kathy Davis, and I'm the director of our perinatal, neonatal, and pediatric palliative care programs at KU. First, I'm mortified to hear of those things happening, and I've been at KU for almost 40 years, so I remember when we had days that were characterized by physicians believing that any unborn baby with a disability may not be what was called a viable pregnancy, or that the fetus may not be compatible with life, and all of those terms were so distasteful to even have to deal with. However, I've seen huge changes in the last several years, and I would be shocked to hear physicians making those kinds of statements nowadays. Not to say that definitively it wouldn't happen, but it certainly is far, far from the norm. I watch a lovely new situation where parents and physicians are very much involved in shared decision making, but where we work completely within the realm of what parents' wishes are and ensure that they have appropriate information to enable them to make appropriate decisions for them, their unborn child, and their family. I also watch parents struggling terribly when they are carrying a fetus that may have anencephaly or no brain, a baby with no kidneys, babies that have holoencephalopathy or other diagnoses that can cause babies a great deal of pain and suffering. And those parents who are really struggling with what to do in regard to their pregnancies and how to support their child. So it's a horrendously difficult situation. My heart goes out, Leslie, to you and to any others who had those kinds of early beginnings. I started my career as a special education teacher, and certainly know that there is value in every life that can be lived. So anyway, the good news is things are getting better.
We've got a few more questions, lots of things going on in the chat, but I'm wondering if our speakers could talk a little bit about consistency of care and trying to avoid the concept of too many cooks in the kitchen.
You want to go first, Dot, or?
Yeah, you go first. I'm thinking. I will say one thing. I think I see a urologist, a neurologist, a dermatologist. I have the whole list because I have a number of conditions. One of the difficult problems I've experienced is if I see someone outside the KUMC system out of necessity, as one resident said to me, getting those records into my chart takes an act of God. That's a very narrow response to your question, but I'll tell you the time I have spent trying to get records into the system so a KUMC provider can see them was significant. And sometimes I just don't bother. So they don't have all the information they need to truly treat me. So again, I'm not holding everyone here responsible for hospital systems that are archaic and bureaucratic, but boy, it's hard. And you've probably all experienced it too, but when you see like 6 different specialists and try to coordinate care, and there really isn't someone under my insurance plan to coordinate for me, it's really, really hard. I'll leave you with that, Dr. Hall.
I've had I was trying to count on my hands while Dot was talking how many different doctors I see. It's a lot. And I do have a couple at KUMC and many others that are not. So it is hard. And I've got just a really thick file folder of everything that I keep. I make sure that I have a paper copy of everything so that I can take it to any doctor that I do see who's not on that system. I see this as a failing not of any particular hospital system. It's just our healthcare system in general.
Yeah.
And I can tell you the best experience I ever had was at the Mayo Clinic. Talk about an integrated care system where everybody knows everything that's going on, and you can see all the specialists and they actually talk to each other, not just share medical records. That would be my vision for what everybody could get, but I don't know that that's ever going to happen.
Yeah.
It is, and it's really hard if you put any kind of cognitive disability in the rest of it. And so I manage my own health, and then I manage my mother's health too, and it's a full-time job. Yeah, and I don't know. I mean, there are patient advocates out there, but they're few and far between. I think that's one route. There are case managers. People in Kansas Medicaid theoretically have a case manager assigned to them if they have complex medical needs. But it's, even if that's your job and you have 200 people that you're watching, it's a really hard thing to do. I don't have a good answer. I wish I did. I just know that it's an issue, and the way that our healthcare system is set up and the way that reimbursement is done does not support a better, more holistic approach at this time.
Sounds like a lot of personal responsibility.
Yes, it is. Or family members, yeah.
It's a part-time job.
Someone else posted earlier, if you could just touch on maybe in thinking about the American Disabilities Act, what are some strengths and what are some things that need to be improved? I feel like that's going to be lopsided, but what are some things that are good about it, and maybe some things that we need to focus on improving?
I'll just start briefly. I think we need to remember that the ADA is a minimum standard. It's the minimum that can allow people to use the built environment in some systems. It's not the optimum, and some places don't even reach the minimum. And it doesn't address a lot of what we're talking about today, like bias, diversity, language, all those things. But I think it does have a lot to do. I'll let Dr. Hall talk about the healthcare system and healthcare coverage.
So when the ADA was being written and crafted by people in Congress and disability advocates, there was a conscious acknowledgement of the fact that healthcare was a bridge too far, that if you tried to put in non-discrimination in the healthcare system, it would never pass. That was 30 years ago. So it was left out. And then 20 years later, the Affordable Care Act was passed. And I think some of the biggest pieces of the Affordable Care Act really do help people with disabilities. Medicaid expansion, which hasn't happened in Kansas, has made Medicaid available to so many more people with disabilities and allowed them to be employed and not lose their Medicaid coverage. Being able to stay on your parents' coverage until age 26. Pre-existing condition exclusions being taken away was huge, because obviously disability is a pre-existing condition. Annual and lifetime caps on coverage are gone. There are so many things that the Affordable Care Act did that are so important, but as Dot said, it doesn't even touch the attitudes and the environmental barriers that are in there. They're still there, and legislation really can't change attitudes. That's just a reality. So I think we have come a huge, long way. And even the healthcare system in the last 10 years has seen remarkable changes that I wasn't sure I would see in my lifetime, but we still have a long way to go. And I would say one of the biggest failings of the Affordable Care Act, and it was in the law originally, but it got dropped pretty quickly, was a long-term care system. It's a huge problem for many people with disabilities who need personal assistance in their homes and in places of employment. It just didn't happen. It was in there, but then they did a cost estimate on it and took it back out. So I think that's, for people with disabilities, that's the piece that's still missing. That's not part of commercial insurance. It's not part of Medicare, even though that covers a lot of people with disabilities and seniors.
And I didn't mean to be critical of the ADA. It was a tremendous accomplishment. It raised awareness of disability. It just raised awareness that people with disabilities have rights. But it was what could be passed 30 years ago. And we need to protect what we have, because there have been efforts to weaken the ADA, but we need to move forward. And there's a lot more work to do.
We had one other good comment by Misty Clarkson, and she wrote, I asked my patients, can you please tell me what you understood about the instruction we just reviewed? And instead of, do you have any questions? Now let's talk about your questions.
I do that sometimes with students. It's like, okay, we just had an hour-long lecture. What did you take out of it? So yeah, I can see that's very valuable.
As a former teacher, I did the same. Very good. Jeff, do you see any other questions or comments on the group chat?
Sorry, I was muted. There are a lot, and I'm just overwhelmed, I admit it.
Okay.
I'm trying to type a question into the chat, so I'll just ask it, and you can help me fumble my way through the actual proper phrasing of the question.
I'd be happy to.
Can you folks speak about concerns, strategies, good practices for providing healthcare across the lifespan? So it's a multi-pronged question. One is, as a person with disability becomes older, how do their needs change? The other part of the question is, as someone who is the responsible person for a individual, so I'm the advocate, for instance, for a younger person, a child with Down syndrome, as I age, how does the healthcare sort of adapt? So it's an age question more than a disability question, but how do we factor in that changing need?
In 30 seconds, right?
Yeah, sure.
I'm going to respond as a 64-year-old who recently had a stroke and is dealing with a lot of energy issues. I'm starting to decide which issues do I have time and energy to deal with, and what do I let go, and what are the implications for that. So that's very personal, but I think, you know, I'm way beyond the point where I can address all the issues that come up. So how do I put the fires out? And I think I don't always feel that healthcare providers help me make those decisions. So I make a lot of them on my own and hope for the best. So I think another issue is there are not, I've just been reading, there are not a lot of geriatricians, and there's going to be a huge shortage, and there's a lot of us aging. And I think that's going to have really huge implications for how we address staying healthy and functional as we age, for everyone, not just people with disabilities, but particularly for those of us who are already dealing with limitations. So that's my 2 cents worth.
That was one of my elements, was that gerontology exists for a reason. And that's the cooks in the kitchen part. Is,
right.
You know, you need to have a coordinated care provider, someone who understands all of the different pots that are boiling on the stove at the same time. And I think that with a disability factors in, that just really complicates things in a way that is not typically appreciated by someone who's not focused on disability needs.
Yeah, good way to put it.
I would add that there's just a lot of unknowns because people with disabilities are living longer and aging with a disability that hasn't necessarily happened in the past. I know that people, for example, with Down syndrome, and Moya could probably talk to this better than I can, have higher rates of dementia-related conditions at younger ages, but they're living that long, and that's, you know, a new challenge for families and providers. People with amputations, traumatic amputations, you know, that use artificial or that use prosthetics, skin breaks down as you get older, and it's harder to use those prosthetics. And how can we change technology to address that? Living with traumatic brain injury into old age, you know, how does that look different as you also have aging processes with your brain? I just think there's geriatricians and specialty providers have their work cut out for them, because I think there's going to be a whole new set of concerns that people with disabilities have as they live longer.
Yeah.
And I don't think our system is prepared for that either. They're not prepared for working with people of any age, but especially as they get older, I think it's going to be more of a problem. And the other thing that I would point out, talking about age, is and there's probably people on this call that can address this better than I can, but we did a series of interviews of people who have autism spectrum disorder, ASD, and the transition from pediatric care to adult care is often very rocky, because there's not this acknowledgement that these are people who grow up and they're adults now with ASD, and there are not providers that are comfortable with that. So there are a lot of pediatric conditions. There's other things that, you know, people are born with, like osteogenesis imperfecta, that you're born with that, and pediatricians learn how to deal with it and know how to treat it. But as those people age into the adult system, the specialty providers aren't there anymore, and doctors know how to deal with a lot of disabilities that are developmental, that, you know, you're born with or you develop pretty early on. So aging into the adult service system for those individuals is really hard. Another person, you know, we interviewed a woman with ASD who was 25, and she said, I've never had an OB/GYN exam because I'm still seeing a pediatrician. That's the only one who will see me. So it's a really sad state of affairs, and I think that's another whole big place. So we have the aging end, where I think there's going to be a lot of new issues, but we also have the young people end, where there are just not adult providers who understand childhood disabilities.
Yeah,
No, there's another element. Oh, I'm sorry, go ahead, Moya.
This is Moya again. I absolutely agree with you, Dr. Hall. Probably one of the other things that, because of my work with Down syndrome, has moved me into is this transition period. You know, the pediatricians were pretty comfortable because those kids all lived, but now they're aging into adulthood, and we don't know what to do with them.
Yeah.
And it's really hard to even find, you know, I can provide primary care, but when specialty, it's really hard to find somebody that's willing to help you manage some of these specialty things. And so, and this is a whole gamut of people.
Yeah.
You know, kids with spina bifida that are now adults, and kids with with autism that are now adults, and girls with Turner syndrome. We just started a Turner syndrome clinic because there's so many girls now aging, wanting to come into adulthood. And it's just, it's tremendously hard to find a cadre of care providers for them for all their special needs, because adult providers just don't know it.
I have another sort of related question to the aging continuum, and that is the difference in perspective necessary when working with a person with lifelong disability versus someone who has an acquired disability at a certain age. So there's a number of different ways to go with that question. Why don't you choose what is the most valuable answer? Yeah, that's a big sigh.
Yeah.
Actually, one of my doctoral students just wrote a paper on this, and I'm trying to remember what she found, but she compared people who had early onset of disability before age 22 and people who had onset of disability later in life. And I don't know what the right way to say this is, but people who had disability at an early onset were really coping better with their disability, I guess, because they had never known anything different. Whereas if you acquire disability later in life and you have to change the way you've done everything, it's harder. And so I guess that's my one insight there. It's like,
I think that's an important insight for people to hear, though. That mostly when we talk about disability, we're focused on the disability we're most familiar with.
Right. Right. And so, yes, it's a different experience for somebody who's born with a disability and has been supported and included throughout their lives versus someone who acquires one, and it's a whole new life for them, really, at some point in time where they're probably set in their ways.
We had another good question or comment in the chat. Dana Reinert wrote, one thing I'm trying to do is more purposeful about following and sharing good resources on social media. Are there specific organizations and or people you'd recommend for following on Twitter, Facebook, or Instagram?
My dog has stopped barking finally, so I'll just weigh in to say I don't do a lot of that myself, time-wise. But someone mentioned Alice Wong's book, and I think there are some like for people with spinal cord injury, the Christopher Reeve Foundation has some great support groups and resources online. I know more disability-specific ones. As far as general ones, but we could research that. We certainly could look for some and post them if that would be helpful. But it's a really good question because that's a good way for people to get information.
And I would just throw out there, Centers for Independent Living have information and referral as one of their core services. So no matter where you are, there's likely a Center for Independent Living somewhere close by. These are disability service organizations run by people with disabilities. And peer counseling and peer support is one of their core services also. So if someone is new to a disability and needing that support and adjustment, that's a good place to go. And they know the local resources wherever they are.
And I see that some other resources were just added to the chat. So thank you so much for that. We will add those in as well. Are there any other questions from the, are there any other questions to the panel? No?
Well, we'll look to hear from you guys about changing the curriculum for medical school students. Just, give us a call.
Hey, let me put a vote in there for more than just the medical students.
Okay, there you go.
I think one thing we've done, we reach out to the disability community to not just present the academic side but also to present personal experiences. So I think we could be really helpful, and we'd be happy to. I think it's all important. I think we're reaching our Zoom limit. Maybe it's time for a break.
I think you are correct. So I think we will part here for a 10-minute break.
Thanks, everyone.
Thank you.
Thanks.